Thank you very, very much for that introduction, and thank you very much for giving me the opportunity to address this group. It's really quite a privilege. Um, I have some slides, and I thought I'd go through them. If you go to the next slide, please. Um, so, can I advance the slides, or is that up to you? Oh, there we go. Okay, so what I'd like to first kind of go through is some of the sort of basis for the PEPFAR response. So here's some things that we really know about COVID-19. We know that the best way to prevent illness due to COVID-19 is to avoid being exposed to the virus. We also know that that the virus spreads mainly person to person, and especially between individuals who are in close contact and inside. Infected respiratory droplets are produced when somebody coughs, sneezes, or talks. And we also know that speaking loudly or singing is a very efficient way to spread COVID-19. And this, of course, has important implications for the faith communities. We know also that COVID-19 is spread mainly by people who are not showing symptoms. And in fact, I heard a talk this morning in which we now know that the outbreaks that are associated with the healthcare environment are really spread by people who don't have symptoms. Can you go to the next slide, please? So we also know how to prevent COVID-19, and really the most important things are really the personal protective behaviors. These include hand hygiene, which is hand washing and the use of alcohol-based hand rubs, respiratory hygiene, and what that means is covering a cough and using tissues, and really anybody who is coughing should wear a mask, and face coverings, and I'll talk a little bit more about that. The other important thing is social distancing. In other words, staying far apart if you have to be near somebody. Some terms to know that I'll talk about a little bit is this notion of continuous medical masking. That means that healthcare providers wear a medical mask from the time that they start their shift in a healthcare facility to the end of it, and that includes tea breaks, that includes in break rooms and in cafeterias. There have been several outbreaks in the healthcare environment that have been associated with healthcare worker to healthcare worker transmission in the lunchroom. Universal source control is a little bit different. What that means is that everybody who has everyone wears a mask to prevent the transmission of the virus. The other thing that I'll talk a little bit more about as part of COVID's PEPFAR's adaptation is differentiated service delivery. Our commitment, PEPFAR's commitment, is that services must be delivered safely, and we're actively working to make sure that all of these interventions that we know are effective for preventing COVID-19 are implemented in all of the environments. Can you go to the next slide, please? So, so the most important thing that we talk about, we are committed to the people we serve, and ensuring continuity of care for people living with HIV is a critical goal. We want to provide that care safely, so reducing the exposure of staff and clients to COVID-19 is critical. In the next slide, please. So the continuity of care, I'd like to say a little bit more about that. We want to ensure that the almost 16 million people who are living with HIV who we serve continue to receive life-saving ART to stay healthy and maintain virological suppression. The strategies that one of the bigger strategies that we've talked about is multi-month dispensing and decentralized distribution. And I'll show you how that has how we've implemented that. We are accelerating key interventions, and one of the more important ones, or if not the most important one, is convenient client-centered care and delivering the right care at the right time for the right people. One of the things we've done is we've separated clinical care from drug dispensing because they really are two different activities. And it really has made a big difference. Safe and appropriate care. So real attention to infection prevention and control activities, making sure that everybody's wearing masks, making sure that people who enter a healthcare facility are making masks. And part of that really has to do with caring for the carers. And that, I think, is an important element that the faith community can really have a very big impact on. Next slide, please. So one of the things that we've done is to adapt differentiated service delivery to protect the recipients of care and healthcare workers. So we've tried to decrease contact with healthcare facilities when appropriate, but it's not always appropriate to decrease the contact. We know that one of the biggest things that's happened, and the Archbishop talked about this in South Africa, is that people are not accessing facilities when they should. So we know that TB diagnoses are down, and that's a big problem. But it does mean that people who are well shouldn't have to come to the clinic or to the healthcare facility. Multi-month dispensing, which includes other medications such as tuberculosis treatment and medication for other conditions such as hypertension, is really has been adapted and been included in the PEPFAR response. So really looking at the whole patient, trying to figure out what it is that they need to stay healthy. Visit spacing is important, and there's a big initiative trying to adapt differentiated service delivery to people who have advanced HIV disease. The social distancing element has been quite challenging, and we're trying to incorporate it into the differentiated service delivery models. And part of that, one of the things that we are trying to do is figure out how these group models, such as teen clubs and interventions like that, can be adapted to the differentiated service delivery model. And we're working through those details. Can I have the next slide, please? Just in terms of multi-month dispensing, we have this has really been an activity that has been really pushed forward. We know that 27 of 51 PEPFAR supported countries have changed their multi-month dispensing policies or implementation to increase the multi-month dispensing since during the COVID-19 response. So this is, these represent countries that have changed their policies, not that already have it. Can I have the next slide? The other thing is that we're doing is really decentralized drug delivery. So home delivery through community health workers, through faith leaders, postal service, all these ways, creative methods for getting the drug to the patient. Community pharmacies have been used and automated dispensing. And then the use of alternative pickups, such as drop-in centers and and I know that churches and mosques have been an important part of this. So, the benefits to the client are clear. Public transportation has been very difficult in the setting of lockdown. And the idea is to bring the medication to the convenient, decentralized location and reduce the time spent at facilities. So there's been some cost effectiveness analysis done on this activity. They may cost more for programs, but they're certainly cheaper for recipients of care. And I think that these adaptations are not going to change after when we normalize activities in the setting of COVID-19. I have the next slide. So our advice has been really to review patients now while there's capacity, and to provide support for clinicians in the form of standard operating procedures, translation of guidelines into practice, and really emphasize the role of data systems and clerks. We want to identify patients who are at risk for treatment interruption by patient tracking and establish contact methods, and really figure out how to support that patient while maintaining social distancing. And telemedicine and clinical consultations that have gone on electronically are really have really taken off across the globe. They've been a method in telephonic consultations have been done for a long time in the United States, but they're really, this kind of conversations with different cadre of providers has taken off in PEPFAR as well. Can I have the next slide? So what have we done to try to figure out how to help adapt PEPFAR to our programs? Well, I lead an interagency collaboration. That means from different parts of the United States government, which really consists of a number of people in the implementing agencies. USAID, CDC, and CDC are examples. And we have been providing guidance weekly based on the rapidly changing landscape. And we've been trying to respond to questions and issues from the field. So the guidance is posted weekly and posted on the public website. The first link there will take you to the COVID-19, the PEPFAR COVID-19 resources, and you can see that, and I've given you a screenshot on the right side of your screen showing this is what you get to, and you click on that 917, and that will be the updated technical guidance. And there'll be another guidance posted tomorrow. So the other thing that we've done is we've actually had developed a public input mechanism where we are able to respond rapidly to questions from the publics, and we invite you to make comment and ask questions on the public forum. I can tell you that we see these questions and we respond to them. If you go to the next slide, I'll show you. So these are the kinds of questions that we have fielded, and numbers. We've developed over 130 frequently asked questions, and on the public website, there's been at least 70 different questions, some of which have made into the guidance. Others we have answered directly to the person who's made the requirements. So that's kind of where we're. That's what we're trying to do, to be absolutely responsive to the needs of people on the ground, and I hope that by giving this talk that you can participate in the adaptations, the COVID adaptations themselves. I come from a technical lens, but we are very aware of and believe that the community and faith community in particular response is really important to developing a therapeutic alliance between between sort of headquarters, the recipients of care, and the people that support them. I think that may be my last slide. So I'll end there, and I'm very happy to take questions should that be appropriate.